Hello, this FERNE video addresses the issue of emergency department patients with dizziness and vertigo with the attempt to diagnose and treat serious central etiologies. This educational video will address the physical versus central bedside physical exam findings. My name is Edward Sloan. I'm an emergency physician in Chicago. I serve as the FERNE president and board chair. I have no financial conflicts. Please go to our ferne.org website and our YouTube channel for more information related to the care of all patients with neurological illnesses, injuries, and emergencies. The information I provide to you in this video comes from the Timing and Triggers Approach to the Patient with Acute Dizziness, a great monograph by Dr. Jonathan Edlow, published in 2019 by EB Medicine. So we are going to talk about the 5 physical exam findings that can help to distinguish central versus peripheral etiologies for acute vestibular syndrome. So in patients who present who are profoundly dizzy and have continuous dizziness right in front of you, there are 5 things that you need to determine clearly. The first has to do with nystagmus. So nystagmus can either be relatively normal, related to peripheral etiology, or more sinister, related to a central etiology. In green, what is a peripheral type of nystagmus? If it is horizontal and direction fixed, that is, the fast component always goes to one side, such as to the left, and it beats away from the affected side. If it goes horizontal, unidirectional, away from the affected side, this suggests a vestibular problem on the alternate side. Central nystagmus is nystagmus that can either be vertical, torsional, round, or dominantly horizontal but direction changing. It'll be fast to one side, fast on the other side, depending on where the gaze goes. So bidirectional, vertical, or torsional is more sinister central nystagmus. What is the test of skew? You alternately cover one eye, and then when you uncover the eye, a normal peripheral finding will be that there's normal pupil alignment. There's no need for some reassessment or corrective vertical motion. This is normal, suggesting a peripheral etiology. However, if there is skew deviation, if when uncovering one eye or the other eye has to vertically align the 2 pupils, this would suggest a central etiology. What about the head impulse test? What is a peripheral finding? If on one side, with moving the head, there is a corrective saccade, but not on the other, it means one of the vestibular systems is failing to work appropriately. That would suggest a peripheral etiology. If, on the other hand, there is no corrective saccade on either side, it means both of the vestibular systems are healthy and there is likely a central etiology. What about the targeted neurological exam? Well, a peripheral etiology would demonstrate no cranial nerve, brainstem, or cerebellar signs. A central etiology, on the other hand, may demonstrate limb ataxia, dysarthria, diplopia, ptosis, anisocoria, facial sensory loss of pain and temperature, or some unilateral decreased hearing. Last, gait and truncal ataxia. A person with peripheral etiology should be able to walk unassisted and sit up in the stretcher and or stand or walk without having to hold on. On the other hand, a person with a central etiology to their vertigo may be unable to walk without a wide base gaze or may not be able to sit in the cart without holding on to the rails. So what we know here is that there are 5 important physical findings, and we know what are peripheral versus central findings. If you have any comments or questions, please get a hold of us at ferne.org, at gmail.com. Thank you for your time, and have a good day.